আছে দেখা যাবে এই তো এসে গেছে now it is visible sir
thank you so the topic which has been assigned for me is a wholly quartet of clinical evidence for decision making in choosing appropriate oral antiplatelet agent in acute coronary syndrome. So what is the meaning of this quartet? It's a team of musicians, and on the discussion today we'll have one musician whose name is pathophysiology of acute coronary syndrome. The second musician is the clinical trials and real world evidence or registries, and the third one is the guideline recommendation, and the fourth and most important also the quality of molecule what we are going to use. At the onset I will clearly say that it has been sponsored by the pharmaceutical company makers of TICAGRELOR. Now, these are the 4 issues. So first of the team 4 is acute coronary syndrome and platelet activation. We need to just recapitulate. Remember one thing, acute coronary syndrome is a dynamic process, and we treat the physiology mostly, try to decrease the myocardial oxygen demand by optimizing the heart rate and blood pressure and relieving congestion in more sicker patients. But most importantly, what is happening inside the heart is the activation of the platelet. And for that, a standard stigma is to give a triple combination of aspirin, antiplatelet, thienopyridine inhibitor, and a large dose of statin. And that has been shown to be marvelous at the beginning. And even if your patient is not suffering from acute coronary syndrome, you are not doing any harm to the patient. Let me focus a little bit on this picture. Now, what this picture says, that platelets, they go on rolling inside the vessel. This is the endothelium, this is the tunica media, this is the tunica externa. And the moment the endothelium is denuded, it gets attracted. But here still, if you act quickly, you may prevent further propagation. But once it has been tightly bound to the endothelium by another ligand, L2B1, then it attracts another platelet through fibrinogen. So the ongoing process of acute coronary syndrome goes on and masquerades into a irreversible myocardial injury. And there are novel therapeutic intervention already we know to inhibit the receptors on the activated wall of the platelet. And the most important and the gold standard, the COX inhibitor aspirin. And also there are P2Y2 inhibitor, which is the talk of the day today. You must have been seen that the use of glycoprotein 2B3 inhibitor has calmed down a little bit. And shortly I will going to explain you why it is so. And these are the future studies on P-selecting inhibitors targeting to other receptors which may be more effective. But as of now, we have a very clear concept that if you can give a P2Y12 inhibitor, your platelet activation is minimized, and that not only decreases the myocardial injury, but with reperfusion, it decreases the chances of infarct size. And the factors relate, namely, are this, and these we are not going to remember in the bedside. Just for the beginning, I discussed this thing. Now, what antiplatelet agents we have in the therapeutic armamentarium? Many, but the most important thing is the P2Y12 inhibitors. So there are 4 groups. Irreversible is clopidogrel, time tested, less costly. Prasugrel, little bit costly, very good, but remember irreversible. What do you mean by irreversible and what do you mean by reversible? We know, but still on the course of discussion we are going to do it. And there is another, ticagrelor is an oral antiplatelet drug, our molecule of the discussions today, and cangrelor is an intravenous short-acting antiplatelet. The beauty of ticagrelor is it is absorbed from the intestine, whether you crush the tablet or give a whole tablet, bypasses the liver and directly inhibits the platelet, what the prasugrel and clopidogrel doesn't do. And this is depicted by this graphical representation, where in this axis you can see the platelet aggregation percentage with time, and what you can see, the ticagrelor very rapidly can inhibit the platelet in comparison to clopidogrel, and by 2.5 hours 88% platelet are inhibited and your job is done. So if you see a patient with acute coronary syndrome, clinically judged, no ECG, no echocardiography, no biomarker has been done, and if you are given this drug, it actually inhibits the platelet then and then, and that's the beauty of this. Now, the important thing is, in comparison to that, the clopidogrel definitely has a lower chance to deactivate the platelet. It takes a lot of time, and the most important thing is time is muscle. It's not for the angioplasty and fibrinolytic therapy, even for the antiplatelet drug also. The beauty of ticagrelor is, yes, it is directly acting, bypasses the liver. It is reversible. That means if you stop it, you need to stop it either because the patient needs a surgery or the patient has a major bleeding. It can be reversed a little bit earlier than clopidogrel, and it rapidly acts. Its platelet inhibition is fantastic, more than 80%. And pharmacological offset is also faster. That means if you stop the medicine, it quickly disperses from the circulation in comparison to prasugrel. We have really not found any clinical documentation of non-responder to this newer antiplatelet. And also the adenosine, which is the culprit of activating the platelet, is being re-inhibited, reuptake is inhibited by this. With this, I give you a case which I have seen recently. This is the inferior wall myocardial infarction, lead 3 ST elevation more than lead 2. That's means they are right coronary artery occlusion. The patient didn't have any evidence of clinical RBMI, so probably a mid-RC occlusion has been thrombolized with retriplace and came with this ECG, and we did a pharmacointensive treatment with a thrombotic lesion which had been stented, and you can see my advice, the AC inhibitor, the aspirin. I have cut down the drug, it is ticagrelor, and also with the other evidence-based and newer anti-diabetic, which is good for these patients. Now, is it's a new molecule just a myth, or it's a fact that it is effective than that? So we have two trial to comparison. One came in 2009 and another 6 years down the line. The difference between these two, this is for the intervention cardiologist trial, and this is for the all comers, physicians, cardiologists, non-interventionists, for them. So what they say is that if you have a unstable angina or MI, and if your patient is going for a intervention, if you are giving ticagrelor vis-a-vis clopidogrel, it gives a benefit. What is the benefit? We'll see in the next slide. But if the patient is not going for any procedure, just on medical management, still probably it works. So ticagrelor concept of 60 milligram beyond 1 year. And it has shown, can someone please mute his mic who is not speaking? So it shows definitely a significant decrease in 14% decrease in mortality. Remember one thing, it also produced some bleed, but that is not significant. And the drug, when it has been used for high-risk patients, has not gone under any intervention. It was beneficial for them also. Now in this patient, we have thrombolized the patient. Is it a good option to give this strong antiplatelet? So there is a trial called TREAT trial which came in American Heart Journal 3 years back, and we addressed exactly the same issues. So what they found, the majority of the patient received clopidogrel pre-randomization, and based on the result, STMI patient, if they are less than 75 years, can be switched to ticagrelor in first 24 hours of fibrinolysis, and it doesn't increase the bleeding. But does it increase the decrease the incidence of mortality overall? Yes, in plateau trial it is. In plateau trial, irrespective of initial treatment strategy, it is so. And what the real evidence says, in Sweden, it has been shown that people who are on ticagrelor has a cumulative incidence of death, MI, stroke, down the year of 700 days is less. There is an Asian population group in the Taiwan where they have shown that the chances of survival is more if the patient is on ticagrelor. So survival is better. Now, Sheffield study registry also shows them. This is a trial from the India, New Delhi, what they have found that the major bleed, life-threatening bleed, is not actually more in clopidogrel vis-a-vis ticagrelor. So the issues of bleeding is not a matter of concern. But remember one thing, the clinical judgment, what we are discussing today, trumps over anything. So in the bedside, you have to understand very clearly, is my patient is at high HBR? High bleeding risk means that if you have a score of 1, that is one major criteria, or 2 minor criteria, 0.5 each, your patient is at HBR. So where a long-term ticagrelor therapy has to be balanced against the risk of thrombotic event. If a patient has diabetes with long-standing medication, second, spontaneous myocardial infarction, multivessel disease, mild renal dysfunction, they should receive it. But the moment the patient goes into a very severe renal dysfunction, that is creatinine clearance less than 30, and definite history of thrombocytopenia, spontaneous non-ICH bleeding, anemia. Remember one thing, the definition of anemia is not hemoglobin 10, less than 12. So many of our patients may have mild CKD and mild anemia. And on those cases, if they are more than 75 years of age, you need to calculate creatinine clearance. Please don't go by just creatinine, and then have to very wisely judge that you are going to continue on clopidogrel or on ticagrelor for this patient. With this thing in mind, last year, ACC guideline has come up, ESC guideline, in this way, that if the patient with acute coronary syndrome without revascularization or fibrinolytic therapy managed medically should receive ticagrelor over clopidogrel if no high bleeding risk is found. If the high bleeding risk is found, then 1 month clopidogrel and only aspirin. But if you think that the patient is a high bleeding risk and high thrombotic risk, you can use ticagrelor clopidogrel up to 6 months. This is a class 2B indication, not class 3. Similarly, PCI, they all should receive the newer antiplatelet until and unless the HBR is there. If the HBR is there, you need to give still 6 months of newer antiplatelet, not 12 months. In some cases, you can come down shorter if you find that the patient is bleeding. So this is the take-home message. DAPT, irrespective of the initial study, must for 12 months. Beyond that, you have to understand the thrombotic risk vis-a-vis the bleeding risk on these patients. Ticagrelor is the only drug which can be switched with clopidogrel, not prasugrel. So if your patient has been treated with clopidogrel, you want to switch to prasugrel, you can go ahead. This is the slide provided from AstraZeneca. It is true that some of the patient who has received clopidogrel earlier, not the generic versions, and from other companies during generic, they found a increased in thrombosis rate, which is a deadly one. So hope with ticagrelor this doesn't happen. So if the patient is on high risk of thrombosis, enlargement stenosis, multiple stent, over body weight, try to be careful on the using the brand of ticagrelor you are using. So this is how your process and the molecule both together should win the game. And with this, I end it here. I'll be happy to take any questions. Thank you.